Thank you very much, Dr. John Thanakumar and Dr. Kona Kumari and the organizers for giving me this opportunity to just have participation in the debate. And today is the era of data. And Edward Deming had beautifully said, without data, you are just another person with an opinion. So what I did was that I went backwards, worked backwards from 2023, I have gone back to 2017. And I have searched the data on which one is better for incisional hernia repair, laparoscopy or open. I am not going to show my videos, but these are the publications which are there as recently as August 2023. And in this, one can find out that outcomes of recurrent incisional hernia repair by open and laparoscopic approach, a propensity score matched comparison. And in this, it was found in laparoscopy, the operative time is definitely less and stay in the hospital is also less. Whereas in open surgery, open incisional hernia repair, the incidence of surgical site infection is definitely more and hematoma is definitely more. Though this publication says in long term, the recurrence rates are more or less similar. This is a rider. And then there was again a publication in 23, updates in surgery, and in this, what they have done is, all of us know about European guidelines, all of us know about American guidelines, so I have chosen Italian guidelines, and in this they have gone into lot of details about how to, why this is gone? Dr. John is doing this? So which one is better according to the mortality, morbidity, recurrence, quality of life. Quality of life after laparoscopic surgery is far, far better. Length of hospitalization is far less. Post-op pain is far less. Costs are now, initially, open surgeons were against the laparoscopic surgeons because they were mentioning that we are going to put in a large dual mesh, and dual mesh is a costly affair. But with the advent of ETEPs and other procedures, we have been able to use even 30 by 30 size Prolene mesh in the retromuscular plane, that too by laparoscopic method or robotic method, and the cost issues overall have come down. And this publication has graded, and GRADE, grading of recommendations, assessment, development, and evaluations methodology. I'm not going to bore you with this busy slide, but I have just made the recommendation that, for example, in this publication, they have just compared straightway laparoscopy versus open, which one is better, and they have said that if the hernial defect is smaller than 10 centimeters, laparoscopic surgery is definitely better. In those elderly patients, for example, more than 70 years, laparoscopic surgery takes over. Obesity, more than 30 BMI, again, laparoscopy is better. And if the patient is presented with emergency, it is good idea to do a diagnostic laparoscopy and then go in for whatsoever the best patient can have, go ahead and do it. But ultimately, our answer is, please take care. He's doing, yes. Somebody is conspiring against laparoscopy, though he has already conceded that laparoscopy is far, far better. And border hernias also, you can see that ultimately laparoscopic hernia, parastomal hernias, definitely laparoscopy scores over. There was a comparison between IPOM and IPOM plus, but once we have started doing the suturing of the defect, the chances of seroma are reduced, so laparoscopy scores over. There is a competition. I would not say it is a competitive, it is just an adding on the tools. So if you go in for robotic training and you are doing robotic abdominal wall reconstruction, definitely it helps. So all said and done, there is, honestly speaking, there is no comparison between laparoscopy and open repair. Laparoscopy scores over very high, and this has been extrapolated also to even primary midline ventral hernias. My discussion was about the incisional hernias, but it has been extrapolated in this publication, and this is again in 2023, and we have seen So many randomized clinical trials also have come out, and they are clearly showing that laparoscopy is far better for incisional hernia repair. The incidence of incisional hernia, I think the point which has to be discussed today in these kind of conferences is that 13% of incisional hernia after a midline laparotomy is too high. So we should discuss how can we reduce this 13%, and almost 80% will eventually need a further operation. This is startling information. So our thinking is that one should definitely dwell on those topics rather than comparison between laparoscopy and open. And they have gone in to that extent that defects up to even 15 centimeters can be tackled by laparoscopy thanks to ETAP and thanks to ETAP, TAR and RS. And again, I am not saying this is the guideline from us, but Italian guidelines, European guidelines, American guidelines, Danish guidelines. So many studies have been there, but I would definitely bring your attention to Todd Hanniford's this publication in SAGES 2020. Are laparoscopy and open ventral hernia repairs truly comparable? They are not. Today, all of us know that open hernia repairs are more likely to be recurrent, complex, require component separation, and more likely to develop post-operative wound complications. So, and all of us have seen those wound complications. And in this publication, in Hernia 2020, again, so much of a number. 35,000 patients had got the open surgery repair done, and 14,000 laparoscopy. But again, I will just read it out verbatim, that laparoscopic surgery was associated with overall low morbidity compared to open repair. The incidence of surgical site infections 1.1% versus 3.5%, post-operative infections 2.7% versus 3.6%, and reoperation rate also is definitely lower after laparoscopic surgery. So once you get yourself equipped and robotically, if you are able to do it, and if you are able to give the best to the patient, nothing like it. Especially I will urge my younger colleagues, please, this is the time to go in for training for robotic surgery and then ultimately make a difference in the life of the patients. And with the advent of ETAP techniques, all of us know that such a beautiful publication, and so much like a wildfire, it has spread, and ETAP has already taken over, and now we are able to put a mesh retromuscular plane without tacking, without pain, without any adhesions, without any complications later on. So why are we going to discuss about laparoscopy? Can you have just for 1 minute, 1 second or 1 minute? Last slide, yeah. And so ultimate answer is that please decide for yourself. You want to remain an old crow, or you want to become a modern crow, use the straw, or just show for 1 second. Just show for 1 second. Can I take for 1 second? 1 second only. Just show that.
Please go ahead.
Go ahead, go ahead.
Again.
Now you want to become a ultra modern crow. So learn the robotics, learn this method, and quench your thirst. Thank you very much. Thanks a lot. Thank you.
Thank you, Dr. Parveen, sir. Now, I would like to call, you remain in the stage, sir. John, sir, come back to you. Put your views across after listening to Dr. Bhatia, sir.
That was an excellent presentation, Parveen. He actually helped me with my difficulty with my presentations. So this is, there's one thing I strictly believe, that is, any data coming from your country or any Asian country is far superior to any other country. We are all different as people, as biological things. We eat different kind of food, we do different kind of work, we do our manual labor. Our women have probably more children than others. There are European, Scandinavian countries where the birth rate is 0. So we have a different set of abdomen, we have different set of rules. Nobody talks about transplant of abdominal wall, whereas it's already being done abroad. So we are no class at all. And if we have to set a class, we have to have our own data. You should talk about your patients. If I don't talk about my experience, I respectfully disagree with with Parveen Bhatia, quoting all the areas of people of countries that we have never visited also. The thing, I'm seeing my patients every day, so it's got to be based on us. But the message that should go to everybody is, if you are going to be only an old surgeon saying laparoscopy is bad, that's a no-no. Because very small hernias, you can do it with a laparoscopy. Very large hernias, I mean, you can do it by open surgery, which is more cosmetic. Very large hernias, abdominoplasty, especially in women, whom we know the commonest person for even a primary ventral hernia, which my learned colleague quoted, is abdominoplasty. You know, the woman stands like this, and a person who is wearing a sari, covered herself, will come back on the shurta to come and see you, even Coimbatore, Sauripalayam. So you must remember, the cosmetically also, our patients are different. And you have to look at my class of patients, because I'm not going to practice in Italy, nor am I going to practice in France or whatever. So that's my rebuttal. Thank you.
Appreciated, sir. Dr. Praveen, sir, your rebuttal.
My answer is same. God did not create the countries. All of us as humans, we have realized, and after traveling so much throughout the world, that any and every human body is same. Any and every disease is more or less same. And the management has to be same. How can we say that you can do the laparoscopic repair for Italian patient and not for Indian patient? I am surprised. How as a doctor, how as a surgeon are you able to differentiate? When you go in, that does not get it written that it is an Italian liver or Italian spleen or Indian spleen. So it is more or less, ultimately, our thinking is that we have to carry on unlearning, learning, and relearning. So much of change is occurring in the hernia paradigms. So we should definitely be open to that. We should not have a closed mind. There are, let me be honest about it, we killed because of the competition between TAPP and TEP. Why should there be any competition? Both are procedures. If you are good in TEP, carry on doing TEP. If you are good in TAPP, carry on doing TAPP. We started having comparisons, and ultimately patients also thought, public also thought, press also thought that these surgeons are fighting with each other, so that means there is something wrong in it. But ultimately it was for the good of the patient. So our thinking is, yes, you should know open surgery, but today is the era that one should learn TAPP, TEP, ETAP, ETAP-RS, ETAP-TAR, robotic, and sky should also be not, and should not be the limit. Sky should also be not the limit. Thank you very much.